And I think now, as we begin the next session, we do want to, I think, highlight the importance of health financing for health systems resilience. And we are aware that globally, the need for healthcare financing is increasing with aging societies, with the emergence of new diseases and the rising cost of care. And shocks such as pandemics and conflicts and environmental disasters put a lot of stress on fiscally sustainable health systems. And so I think without further ado, I am pleased to introduce Stefan Nachuk, a philanthropy lead from Morris Brothers LLC. He is formerly the Senior Advisor of Health Systems at the Bill and Melinda Gates Foundation in India, and he designed and implemented transformative health strategies aligning with the government of India. And with over 2 decades of experience, Stefan has been a key figure in initiatives like the Global Learning Network for Universal Health Coverage and the Center for Health Market Innovations. Our panelists today also include Dr. Alexo Esperato, Senior Health Specialist from the Asian Development Bank, Dr. Chang Liu, CEO of Ask Health Asia, Dr. Jeremy Lim, Associate Professor at the NUS Sauswee School of Public Health, Dr. John C. Langenbrunner, Advisor, Social Health Insurance, Indonesia, and Dr. Kerry Elgar, Senior Policy Analyst at the OECD, who joins us virtually. So may I invite Stefan on stage, please. Over to you.
I know. So we're just going in order. Good luck, you know. Good luck. So you're here. Okay. Jack, you're here. Look at this. This is you're going back to your childhood. All right. Hey, does it work? Oh, it does. Okay, good. All right. Hey, everybody. Look, we got everybody organized. They're sitting in their assigned chairs, and we're. Has Kerry joined us?
Yes.
We have
I'm here.
Lexo, Chang, Jack, Jeremy, and Kerry.
Yes, hello.
All right. Kerry, can you hear us?
I can.
Okay. Okay. What time is it there?
Nearly 4 a.m.
All right. All right. This is the kind of commitment we like to see in the health sector. This is very good. 4 a.m. Okay. All right. So we're going to run through this. There's we were doing this in multiples. So we have 5 people, 3 questions. If anybody can do the math, that's 15 questions. So we'll go through this with one common question to get started. We're talking about innovations in health financing, which is a broad and slightly mysterious topic at times. So why don't we just begin, and we'll go right down the row. We're going in order of first name, okay? Now, first name, I might add, for those of you who are unaware, is the way that the Icelandic phone book actually categorizes people. So people are done by first name in Iceland, and we're going to copy the Icelandic innovation here today. All right, and we're going by first name. So let's start with the first kind of broadest question and get everybody's kind of inputs and thoughts. You have, again, about 4 minutes. Don't panic, but be interesting. Don't be boring. Be concise. Don't go on too long, but don't be too brief. Is that okay? Good. All right. So some people have said that innovative health financing is kind of the greatest thing since we put wheels on suitcases, okay? Other people say there's more smoke than fire to this. There's a lot of talk, but actually it hasn't really systematically or structurally raised the level of health of financial resources, especially for low and middle income countries, okay? So for each panelist, starting with you, Alexo. Can you give me a 30-second understanding of innovative health financing? Just what's top of mind for you, okay, in terms of mechanisms? And then a few minutes, say 3, and tell us why you think innovative health financing is a little bit closer to wheels on suitcases or more smoke than fire.
Okay, thank you, Stefan. So when I think about innovative financing from a resilience context, which is the focus of today's event, I think that most people, at least at ADB, would think about what we call blended financing. What's blended financing? Well, it's a bunch of mechanisms to de-risk and therefore get private capital into development projects. So this can include guarantees. They can include senior debt. They can include other things such as grants and so on. Now, and I'll probably give examples of this later, right? Why is this important? Well, because according to calculations, climate adaptation in low-income countries would require about $1 trillion, and commitments from international institutions are only $100 billion. So therefore, there is a gap of $900 billion, right? So that's what I believe that, that's quite innovative. There's other things that people would group under innovative financing, some people would group, which are not necessarily resilience-oriented, such as new forms of private insurance, for example. Some private insurances work in specific diseases, to give an example. Pairing private insurance with telecom subscriptions, as Telenor tried in Bangladesh. These are kind of old ideas, kind of recooked, right? So these have been around for 40, 50, or 100 years, right? They're just innovations of old ideas. Other group of financing that people often put under, again, innovative financing, I don't think they're that innovative anymore, are sin taxes, right, on the public side, or things like taxes on international transactions, like Tobin taxes, right? Again, they've been around, they're not necessarily new. So I'll stop right here, thank you.
Thank you for Alex for the comprehensive view on the innovative financing. So maybe I dive into one model that at least we observe that made concrete progress in this part of the world, which is sort of built upon the universal healthcare coverage, social insurance, on a supplementary commercial insurance model. So I think I want to just sort of share a little bit the progress made in China, which is a very diverse, big market that on both structurally but also concrete momentum that they made for this supplementary model that really building on a multi-layered health financing mechanism. So I think they started, on structurally establish universal social insurance that cover everyone, essentially. And I think in such over 1 billion population with huge variation and diversity. So I think one of the biggest challenge after they achieve almost entire coverage is to create more equity in that coverage. So the backdrop actually for them to develop the innovative financing bits is the main task to unify the coverage package, the benefit package, in that very diversified population. So I think over the last 7 years, they have achieved, first of all, the universal coverage, almost 99% of the population. And now in the progress in building a unified benefit package for all across China, regardless of economic development status. But as you can see, there are going to be major challenges. Firstly, the depth of coverage, right? That's certainly the UHC that they will be able to build for the entire population won't be able to cover all services or treatments, especially as they're moving from only catalytic hospital care to other primary care, etc. And secondly, also how to recognize the demand for different economic development status on innovative treatments, etc. So I think what they have been doing, I think structurally, I appreciate, and I think for us, we in the last 8 years have been a catalyst in that process, is a supplementary model that they clearly state there will be at least two major components in the supplementary financing, including commercial insurance, population-based commercial insurance, and also charitable donation and the governmental safety net that work together with the social insurance layer, trying to cover as many people as possible. So all those supplementary layer, instead of creating a dual system that the rich go into commercial insurance, but actually created another layer of financing that trying to provide a depth of coverage for as many, like a big fraction of the population in China. Plus, there will be also additional resources that the government and private sector and the charitable sector can put into creating the safety net for all as well. So I think that's really interesting structurally, but in terms of concrete progress, so they have already launched what they call city supplementary insurance that now applied already to over 100 cities in China and cover over 140 million people in China, just over the span of last 3 to 5 years. And also currently, annually, they are sort of this additional pool of funding gathered around 5 to 6 billion US per annum to be able to add into the social insurance layer for financing for the majority of the population. Yeah, so I think I would just stop here, but just one last note is as the technology rapid development in innovative treatments, as well as the needs for primary care coverage, etc., we also see even developed healthcare system like Hong Kong and Taiwan are also trying to figure out how to create more supplementary layer that are more population-based. So this year, I think we'll be able to explore more. Yeah, thank you.
Thanks very much. China's a great story, and I want to come back to it a little bit later in the session. So I've got a few slides, and you know, when I think about innovative financing, there's a lot of innovative financing models floating around, and most people talk about 4 common elements: additionality, additional to normal financing for healthcare services; complementarity. It complements, it aligns with other sources of financing. Sustainability, we all know what that means. And the ability to scale up, So those are the 4 elements that you typically think about when you think about innovative financing mechanisms. So I found, if we could bring up the slides, I found a couple of things on the internet which were quite interesting. ThinkWell Institute has done they've really looked at over 24 types of innovative financing schemes, and they've categorized them into different categories: results-based financing, catalytic funding, impact investing, socially responsible investing, which has come to the scene much more recently. And let's be very clear, I'm very biased with the last, which is new taxation channels. This is my favorite form of innovative financing. And I think that it holds a promise not only for funding, but also for improving health status. So if we could have the next slide. And what they did was they looked at these various categories and they ranked them. They used the OECD criteria. Maybe Carrie has something to do with the criteria. She could talk about that. But they looked at the impact. And you can see that all of these categories received either a medium or a high ranking. But again, my bias is more towards the new taxation channels, which have a certainly high impact in terms of sustainability. And again, they have a great impact in terms of the ability to inform and improve health status. So finally, the last slide I want to bring up is something that I stole from Yurdina's report in Indonesia. Thank you, Yurdina, for that. And it basically looks at countries that are using earmarking for health. So they have different forms of taxation. You can see that there are over, what if you can count, you can count almost 54 countries that are looking at pro-health taxes, either for alcohol, sugary beverages, or tobacco, and earmarking those for reinvesting in the health sector. How are they using it? It seems that a majority of countries, a great majority of countries, 62, are using it to help bring people onto the social health insurance programs in an effort to achieve universal health coverage. I will point out that there are other models besides the pro-health taxes. Ghana has used the VAT tax to help reach a universal health coverage in their country. So it's a very interesting slide. Now I will say that WHO has found that earmarking taxes doesn't always prevail. In other words, you may start with a pro-health tax that is used for healthcare, but over time, ministries of finance tend to move this money into general revenues, and they may use it for other sectors, and that may mean that the health leadership probably has to advocate a bit to make sure that that money continues to be used for something in the health sector. So let me stop there and over to my colleague.
Thank you. Thank you very much, Jack. And thank you, Stefan, for bringing us back to our childhood, lining up in alphabetical order, right? And also telling us effectively to be Goldilocks-like, not too hot, not too cold, right? Not too boring, not too inflammatory, not too long, not too short, right? And I was also thinking about whether to put on a jacket today. And so in the spirit of really Goldilocks, I'll just share that I know I can never be as well-dressed as Cheng. And I know that it's very hard to be worse than Stefan. No, and I raised this purely in jest because we were having breakfast in the morning, and I reminded him it was in this same hotel that I was going to take him for a very nice Chinese restaurant, Michelin-starred lunch, and then he shows up in shorts, and the restaurant says, "I'm afraid you can't eat here," right? So yes, we will be Goldilocks, not too hot and not too cold, and I think that my three colleagues have pretty much covered everything. Let me just make three very quick points. One, if we go back to the World Health Organization Innovative Financing Task Force of 2010, it's not just the mobilization of funds, but it's how the funds are used. And I just wanted to register that when we talk about innovative financing, it's also related to the use of funds. The second point I wanted to make was around something that wasn't in Jack's slides, which is the use of major prizes. And maybe can I ask, just a show of hands in the room, who has heard of X Prize? 1, 2. Okay. X Prize is one of these organizations that offers large prizes, and fairly recently it announced a $101 million prize for advances in longevity. Right? And those of you familiar with the longevity space know that there's no CPT code for aging, and therefore it's not a real disease. Therefore, it is one sector that has really tapped on innovative financing that we can talk about later. But suffice to say that prizes are something that others have used also. And the third point that I would make is that since we're sitting here in Singapore, is that Singapore has broadened the definition of health and use of funds to also include some of these social constructs. In the Singapore budget that was announced last week, 3.5 billion Singapore dollars were allocated to what we call, and that's probably about 2.8 billion US dollars. For a small country, it's a significant chunk of money. And this was allocated to what we describe as active aging centers. These are community-based facilities where the government funds for seniors to gather, to play mahjong, to hang out together. And this is essentially to create the opportunities to reduce social isolation and to use these touch points to provide the nudging for for really behavioral health, such as eating better, going for appropriate health screenings, and really so on. So I just want to make these 3 quick points as we talk about innovative financing. And thank you, Stefan. I will buy you a nice lunch today since you're better dressed.
Hi, can you hear me properly? Yes. Yes, great. So first of all, I'd just like to say it's great to see all of you on screen, and I'm really sorry that I can't be there in person with you today due to other work commitments in Paris this week. But I'll do my best to be as interesting as I can on a screen. Let me go first to the question about, I think, the wheels and the suitcase. Basically, I'd say innovative finance for health is like new antibiotics. They have to be found because a future without them is really unthinkable. So I would say that the wheels are not yet on the suitcase, but the suitcase won't be going anywhere really without those wheels. So on definitions, I agree that there are lots of complex definitions out there on innovative finance, and it's also changing. For many years, I think the OECD definition of innovative finance was the one that was really commonly used, and that referred to any sources or mechanisms on top of official development assistance, so aid, and that this was super widely used, but it's been changing, of course, recently as aid and global public goods financing has become more and more interchangeable. And as the pandemic proved, really health security, like financing, is very much a global challenge. Yeah, it's not just a development problem. So even if the biggest gaps and needs for health are in developing countries, and some of the biggest risks as well, we certainly think about these things as in a more global way than we used to, really just focused on what was additional to traditional aid. So what are my favourite mechanisms? I think I'd agree with Jack that I do like the idea, or in terms of volume at least, of solidarity and financial taxes. And this really we're seeing everywhere at the moment, not necessarily for developmental purposes, but often for solidarity purposes, whether it's voluntary levies that we might pay at the supermarket when we go to pay, or taxes on airplanes, for example, that are voluntary. But, you know, I would say that these are probably the most effective at raising money that would not be spent otherwise. But I also agree with my predecessor that it's not just about the means, if you like, but or the ways, but also about the means. And for that reason, I think it's important to think about what kind of new solutions we're looking at to overcome problems that are not just financial, but that are about different mechanisms. And I'd also say that I'm a fan of pull mechanisms, and the most famous of those is probably the advanced market commitment to develop the pneumococcal vaccine. I can also talk a little bit later about some of the problems with putting up advanced market commitments during the COVID era for vaccines, in that what you think is going to be the problem and the prize you might offer for it is not necessarily going to be the problem in the end, and that there's a way that the objective, if you like, can become distorted. How successful overall has innovative finance been? I'd say that it's not been nearly as successful as we'd hoped when these mechanisms, and they really started around the time of the global financial crisis in 2007 to 9, when we were looking for additional public financing for development solutions. And you know, there was a lot of discussion with Bill Gates, with the G20, for example, on Tobin taxes and other mechanisms, and how we could raise more financing for development. But it's to a certain extent, it's been much harder than we thought it would be to draw in the private sector for these things, even if we know that the future really, if we want to close the trillions in the SDG financing gap and whatever will be beyond the SDGs, that will need to come primarily really from the private sector, not the public sector. So at the moment, I wouldn't say it's a drop in the ocean, but when you compare financing raised from innovative financing mechanisms, they're much, much less than the 800 billion for a year that is raised through remittances, or even the 250 billion a year that's raised in development finance from official channels. So I think we're looking at the moment, I think the latest estimates were about 100 billion for innovative finance annually, but of course we're waiting to see what the latest calculations will be, because that hasn't really been revised officially since before COVID. So no doubt we'll see some changes there. Thank you.
Fantastic. Thank you so much, Carrie, and thank you for actually closing out with sort of an answer to the question we asked, which is high potential, far from there. And I think we're going to get to build on that with a lot of examples now. I might add that if me dressing like a slob helps the rest of the people here feel better about themselves and more confident, I am more than happy to do that. That is a cross that I'm willing to bear. That's a public good that I am providing.
Thank you so much, Stefan.
No, it's not no problem. So let's just go down. Again, we're going to do the children's thing, person by person, name by name. And these are a little bit more curated questions, but hopefully you can build upon some of what you've now already heard. So, Alexo, ADB is a massive lender in Asia. It's got a massive corpus of capital, and that does translate into some degree of power in terms of setting regional agendas or highlighting issues. Can you tell us a little bit about ADB's health system resilience initiatives, and can you kind of draw a dotted line between those resilience initiatives and any sorts of innovative financing mechanisms that you think are highly germane to this?
Yes, thank you, Stefan. And ADB is indeed nowadays a large lender on health in Asia. Just for the benefit of the audience, this was not the case 5 or 6 years ago. Just to give you an idea, ADB only had 4 or 5 fully trained health specialists back then. Now we're over 20, right? Health used to be about 1% of ADB's overall portfolio. Now it's about 5%, which is really not bad, taking into account that ADB has been very active in very large sectors such as energy, transport, urban, and so on. Now, ADB is supporting health system resilience on 2 fronts. The first one is pandemic preparedness, and the second one is climate change. On the pandemic preparedness front, ADB has some pretty large operations in the area. One example is the $125 million project in the GMS, in the Greater Mekong countries. It's supporting pandemic preparedness in Vietnam, Thailand, Laos, and used to be Myanmar. I don't know if it's still anymore. I don't think that that's the case, right? ADB also has large regional technical assistance projects on pandemic preparedness. One of them is the Secure project, which again is supporting these same areas. In addition, ADB is a partner in the Pandemic Fund. You may know it. It's a worldwide facility that gives free money to countries, basically, to strengthen their labs, strengthen their workforce and their surveillance systems, right? So ADB is helping countries access those funds. On the climate change front, you may be aware that ADB aims to be not only the climate bank, but also the climate and change bank. The ADB president committed in 2019 to spending $100 billion on climate change activities through 2030. This was further increased last year. There was a capital increase, 40% capital increase, which means 10 billion additional a year, mostly, but not exclusively, on climate change activities. And at COP28, the ADB vice president committed for all health projects to contain at least 15% climate, either mitigation or adaptation activities. So that means that we have a lot of pressure, okay, project officers to demonstrate that we hit that 15% climate activities. That needs to be certified and cleared internally through our bureaucracy. That means my director, my senior director, regional director, all the way up to the board. we have to show through a dedicated assessment all the various activities that we are doing on climate change. Now, this very big envelope of resources also opens up innovative financing. Let me give you one example. The IFCAP, which is the Innovative Facility on Climate Adaptation Financing for Asia and the Pacific, is a very long name. Essentially, it's $3 billion in guarantees. Guarantees are basically insurance mechanisms for private investors that aim to generate $15 billion in climate change projects in the area. Now, ADB also launched 4 months ago, and I'm involved in this, the Climate Health Initiative. This initiative will generate knowledge, partnerships, and so on, but will also raise funds for climate resilience of health systems. The idea is to generate $10 billion for every dollar invested. So I'll stop here. Thank you. Oh, the question? That was a question. Oh, for him. Oh, yeah.
No, you did well. You did well. You can relax for a few minutes. Thank you. No, it's really. I mean, these are interesting numbers. I didn't quite realize how ADB was beginning to use its heft. This is good and new news. So, Chang, completely kind of we're changing gear here, going to your. So I haven't really worked in the private sector, frankly, much, although we've studied it. I was, as I told you guys, I was a bike messenger when I was 22. That was a private sector job. So I have worked in the private sector. I was highly successful in that. I never lost a delivery. But can you tell us a little bit, you started already in kind of in your introduction, but can you deepen the discussion either through examples, experience, or frameworks about how the private sector really can link to innovative financing? I mean, I think it's a little hard to grasp sometimes, and you're deep into it, so this would be great.
Thank you. So actually, this morning I was debating on whether to put on a jacket, but because Carrie will be on the panel, so I thought, and also I'm representing private sector, I guess, so I'm wearing the jacket. No, no, thank you for the question. I think, nonetheless, we, at least in this part of the world, I think no matter in Southeast Asia or in places like China, there are still a very significant private sector play in healthcare, no matter service delivery or financing. So I think for us, we observe a lot of the effort is how the public system to integrate and to leverage the private sector resources. So instead of creating the dual system that might not be able to leveraging the resources from the rich or the private sector into integrating the private sector effort into the UHC sort of journey. So that's sort of the higher level objective, I feel. Just give you maybe a few specific examples, right? Again, borrowing the Chinese example of the multi-layered financing. So I think private sector actually play roles both in strengthening the universal social coverage through a lot of innovative financing mechanism, and also participating in creating innovative supplementary financing mechanisms that linked with universal social care. So 3 examples in the way that they participate in innovative financing for social insurance. One, actually, so they're starting testing out population-based sort of population health management. So in a few cities in China, WeDoctor, one of the digital health platform, they actually contract with the social insurance to have that capitated payments for managing a few chronic disease, right? So that's sort of the way they're integrating the services, and they take the financial risk, but then working with the social insurance in helping them in testing out the innovative payment model that's more outcome-based. And then another thing I think we always forgot almost on finding new source of funding is how to save funding from the public social insurance. So one way I think China has been doing is what they call VBP, volume-based purchasing for generic drugs. So this is really pushing for the generic drugs substitution. That I think alone every year saved about 10 billion more US per annum, right, for public funding to be able to put into other means. And another way is outcome-based payment. So we're starting to see more and more for innovative treatments, for others, the government potentially starting to testing out in social insurance on the more outcome-based payment mechanism that actually the assessment and some of the implementation are deployed by the private sector. So besides that, I think how private sector plays in supplementary commercial insurance model or charity. Maybe I also give two quick examples. I mentioned the city supplementary insurance model. I think the best case study is in Shanghai. So Shanghai, I think 1/3 of the population, just over the last 3 years, have been subscribing to this social insurance. It's a commercial supplementary insurance model. So this is a public-private partnership, commercial health insurance, that's very low premium. For a city like Shanghai, the annual premium is about $30 per person, right? So it's very affordable for everyone. And they designed this actually government-advised private sector, like IP in Singapore, to be able to leverage in the governmental channel, but it's still a private insurance product that people subscribe to. So that gained a huge population of coverage, but also be able to even welcome people with pre-existing condition to be covered. So essentially, it's not only a commercial insurance, it's a cross-subsidy, another pool of cross-subsidy opportunity that created that's actually sustainable. And then another is on the charity. I think also we need to see more and more vibrant development in charitable organizations here in Asia, right? They also potentially have a role that can work coordinate with the social sector in providing deepening healthcare coverage. So I think one good example is in Hong Kong, the Jockey Club. They recently launched like a 100 million US fund for cognitive healthcare. Right? So they are diving into specific domain that adding funding to social resources in specialty healthcare services. Yeah, I'll stop here.
Fantastic. Okay, this is now we're starting getting in the meat, and actually this will be really interesting because now, Jack, if we can pivot to you, we'll go from sort of the top of Asia down to closer to the bottom, Indonesia. So, Jack, you've been deeply invested in Indonesia's very aggressive health system reforms now for many years, well over a decade. Given that the government has actually raised significantly more resources for health, but is still trying to do a lot with a little, right? Total spend is not super high in Indonesia, but significantly higher than it was a decade or 2 decades ago. Can you articulate some ways in which Indonesia's health financing reforms have innovative financing elements to them, broadly defined, right? And there are some. And what we think we've learned from these efforts to date, right? That would be really helpful.
Thanks, Stefan. So it's a mixed picture in Indonesia, as it is in most countries. But, you know, there are some very positive things in Indonesia. First of all, they've contributed, and they were one of the early contributors to the Global Pandemic Fund. So they almost immediately put in $50 million. That was laudable. And they have a seat at that table, and that's good. They also, during the COVID era, they very quickly went to the multilaterals, and they brought in a lot of money with concessionary loans. And these loans were structured in such a way that the tranche of money came with performance metrics being met. So that was also a very positive feature, I think, in Indonesia. Indonesia has a relatively low debt-to-GDP ratio. So if you go to Japan, the debt-to-GDP ratio is probably 200 or 300%. I haven't looked at the numbers recently. In most OECD countries, it's 100% or above. In Indonesia, the debt-to-GDP ratio is below 30%. So there is some space. There is some space there to borrow, and I think they were smart in doing that. And at the same time, they have a fiscal capacity issue, which is they don't bring in much money into the treasury as a share of GDP. You know, that's depending on the number you see, it's something like 10 to 15%. If you go to Malaysia, it's in the 20s. If you go to China, it's 25%. If you go to Western Europe, it's in the 30s. So Indonesia doesn't have that fiscal capacity that you find in other countries. So it's sort of a macro level, that's what's going on. And but at the same time, you know, coming back to my pro-health tax concerns, if you think about what is going on in Indonesia now, SISTI, we had your Dina talk yesterday, but SISTI has done some very good analytic work on increasing tobacco tax. increasing tax on sugary beverages. Very good analytic work, and they've sent it to the Ministry of Finance. But the Ministry of Finance, as far as I know, maybe I can be corrected later in the discussion part of this session, they're more or less sitting on it, and they're really not moving forward. What is the percentage of men in Indonesia who smoke? Can anybody give me a number? Depending on the estimate you read, is somewhere between 60 and 70%. 60 and 70% of men are smoking in Indonesia. I mean, that's an embarrassment. That's an embarrassment. And yet the tobacco tax is one of the lowest in the region, if not the world. So this is really an opportunity for them to step up, especially now with the elections. There's going to be a new president coming in the next few months. It's really an opportunity for them to step up and think about what they could do. There's also a final area, which is the fuel subsidy. For 10 years, they've been talking about rolling back the fuel subsidy in Indonesia and moving it to health spending. They haven't quite done that. We've had a president who's been in office now for 10 years who promised when he came in to do that, but we're still waiting for that to happen. So again, the new president could take up that charge, and I think really help a lot in terms of raising the level of spending for health in Indonesia.
Fantastic. Thank you. Very common sense. And this is, I mean, and, you know, these are the struggles. I mean, I think you've highlighted that these are also, these are not technocratic in nature. They're political in nature in many cases, right? And that's often the harder case. So, Jeremy, now let's pivot between the two to Singapore, if we could, and just ask you a bit of a TBU, a true but useless question with a twist, okay?
Thanks.
So Singapore's achieved, you know, has reformed its system in some unique ways, especially in terms of financing. But at the same time, you know, what works in Singapore, it's rich, it has strong state capacity, it's a small country, may or may not work in other low and middle income countries in Asia in all respects. So could you talk about one or two TBUs, here's the twist, true but useful, in terms of lessons that Singapore's health reforms, in terms of financing, you think do hold for other countries, things that actually could be applied?
Thank you, Stefan. I was worried you asked me a true but useless question, so thank you very much for that. I won't say anything about dress code. Beyond saying that, in fairness, I do think Stefan has very good private sector instincts because he's very practical and very pragmatic. I was teasing Stefan earlier because he was in shorts because he was going to take a long walk after lunch, right? And I remember it very distinctly because he had on his Bermudas and his cap, and he told me he was going to walk from Orchard Road down to, I think, down to the other end of the Botanic Gardens. So, and that's the sort of pragmatism that is needed to make innovative financing work. If I look at and of course, to recognize the practical realities, before I jump into Singapore, let me just share one little anecdote about Indonesia. I once was in a discussion with one of the MOF policy makers, and he candidly said that 1 million Indonesians work in the tobacco industry. What do you want me to do? Right? Find me other jobs for this 1 million, and I'll solve the tobacco problem for you. Right? So we just have to recognize that a lot of these issues, they are intertwined, right? And solving at the health level may not be the only lever that we need to address. So now let me move to the true and hopefully not useless aspects around Singapore. And I would say that Singapore's secret sauce is in the ability to execute reasonably well because we are a pretty small place. The ideas are not novel. Okay, frankly, please don't tell my minister this, but you wouldn't come to Singapore for innovation. You come to Singapore for looking at how the system integrates and pulls it off in a coherent manner. I think Cheng spoke about using markets, right, in the China example and saving about $10 billion a year. In Singapore, we've been using the MediShield as a platform to attract the insurers, the private ones, to offer what we describe as integrated plans. So they essentially are essentially supplementary plans that sit on top of the national scheme MediShield, hence the term integrated plans. And these then can be harnessed to offset some of the public financing burden, and secondly, to really drive provider behaviors. Something that I think was really politically bold and seems to have worked reasonably well was for the government to impose on the insurers, both public as well as private, that there is a 5% copay on all hospital bills that the individual will have to pay. And frankly, for many of us as hospital operators and as individual clinicians, we generally have no qualms charging the upper limit of normal to insurers and to big, faceless, nameless companies. But when it's the patient sitting in front of you who says, Doc, I'm really worried about the 5% copay, our own prescribing behaviors change in what we price and what we basically prescribe. And so you can then see that the insurers and the institutional payers hitch their wagon on the individual patient. That the system has that the providers have a lot more sentiment towards. So the first true but not useless piece is around market mobilization and really creating markets that can harness that can harness some of these mechanisms better. Maybe the second one that I'll raise and I'll end off, which is something that many countries do, is really simply to offer matching monies, right? There's a lot of philanthropic dollars here in Singapore. They disproportionately go to education and to healthcare because the government offers matching schemes. So not just the tax offsets. Like yesterday, I had to leave. I was telling Krishna that I had to leave in the late afternoon because I went to receive on behalf of one of the charities that I'm involved in a rather generous check. And the first thing that my finance manager said is, let's head down to the Commissioner of Charities first thing tomorrow to see what matching monies that we can get, right? And this then helps philanthropists to essentially think of where to channel money for the biggest bang for buck, right? So I think, and maybe we had the examples can go on and on, but in the interest of time, maybe I will hand it back to you, Stefan.
No, thank you. This is great. And so, and that's what we're looking for is a few examples to start to pull larger lessons. So we sort of zoomed out with Alexo, and then Chang, Jack, and Jeremy have sort of zoomed in on some specific national examples. Carrie, can we zoom out again with you a little bit to bring this home, hopefully, so no pressure. So could you bring home a little bit of some of the links between innovative financing mechanisms and health system resilience? You've already heard people talk about this at some length. How are they practically related, and what did we learn during COVID?
Okay, so I'll try and find, I guess, a story to tell or a logical flow in all that, because it's a really complex question and it depends which end you bite off. But if we start with COVID, I think what we learned during COVID was that while global challenges like climate might be the biggest existential challenges, if you like, we're also reminded that they weren't the only ones that can really affect global stability and where there are linkages throughout economies and societies. So you can't just look at one risk without looking at other risks. And this includes looking at health security risks and all the other dimensions that come into play there. And when you look at health security risks, you also need to keep your eye firmly on this issue of resilience in the whole global health system. So why? And the question, I'll give a couple of examples in a minute, but I'd say that the key risk here is that during the pandemic, we focused very much on security and where those risks may be in surveillance and platform tech. but we tended to lose the focus, if you like, on national health systems. And I think that's where we get to this question about resilience, that you can't have a Rolls-Royce surveillance system without having a really well-functioning national health system, which is likely to be the first chink in the armour, if you like, especially with an infectious disease. So in other words, we're only as strong as our weakest link. So this is just one dimension of that question, though. If you look at it from the funding perspective, yes, we do need more funding beyond public finance. And let me give you an example here through some of our latest data at the OECD. What we're finding now, of course, is that since the spike in COVID financing, both funding for national health systems in OECD countries as well as development aid is starting to decline again. You'd expect this. But what's a bit more worrying is that the shift there has gone more towards surveillance systems and platform tech and away from national health systems. And I'm speaking here particularly about bilateral aid to national health systems, which declined from about 2.3% of total ODA in 2019 to just 1% in 2022. So that's quite a worrying shift in my mind, because it really sort of speaks to the short-termism, if you like, of our priorities, that we look at the next big thing, and yet when it comes to fighting health risks, we're really going to need to be more holistic. And for example, in the G20 at the moment, we're having discussions about what will the next pandemic be. And the next big health shock may well be AMR. So we're focusing very much on a whole range of interventions at the moment post-COVID, but not necessarily focusing on the R&D that might be needed for new antibiotics, which is still a massive problem. And so we're trying to think a little bit more about how you can do that in an environment of fiscal constraint, where public budgets are very stretched by a range of other things and other global challenges, and where we really need to turn back to innovative mechanisms and to being able to crowd in those resources from the private sector. So, and there's also the issues around market mechanisms, because existing market mechanisms, particularly in developing countries, but also more generally in areas like antibiotics and R&D for new antibiotics, are not working. And because other treatments or solutions to health problems may exist, but for example, they're not affordable or easily accessed by people in certain communities or certain countries. So it's really a question around how we balance all these priorities while we try and make our best estimate, if you like, of what the next risk may be, but we may find that it's a completely different risk, as we did with COVID. During the COVID pandemic, we were expecting another Ebola type shock, but in fact we had a very different shock. And that's also interesting in that the investments we made on the development and the innovation side around vaccines were all aimed at vaccines in developing countries, but in the end, that money, which was development aid money, ended up being used for innovations that went first to wealthy countries. So these are big conundrums and problems. I don't have all the answers, but I did want to square the circle, if you like, and point to the complexity of this, and in that there's a lot of unknowns, but we also need to think about how we can balance the risk across all areas, if you like, of health security and health resilience, so that we can best try to manage the resources that we have and to ensure that we don't end up with a great system now for fighting a new COVID pandemic, when in fact the threat's going to come from somewhere else, and we run down our national health systems in developing countries. Thanks.
Okay, thank you. Issues, no clear answers. I mean, this is, and again, I think we're hearing that kind of theme where there's not going to be a silver bullet to much of this. Yeah, so I'm not sure that I would have. I don't think we're going to have a holistic aha moment. But what we're hearing are a lot of 5% solutions, I think, which is, I think, interesting, and a lot of examples of positive progress. Alexo, if we could come back to you and drill down a little bit, you talked about some specific examples of ADB projects in some cases and a couple of specific funds, but could you zoom sort of in and out or sideways and talk about all of ADB's main financing instruments, just to give the group, I don't think the group necessarily understands all the tools that ADB can deploy in terms of financing. And again, draw a bit of a dotted line to anything called innovative financing. That would be really helpful.
Sure. Thank you, Stefan. So ADB's main financing instruments are probably not any different from any other development bank's main financing instruments. I work in a sovereign department. That sovereign means government, right? So we work with governments. And our main financing instruments are loans, grants, and technical assistance projects, right? Technical assistance projects aim to generate knowledge, right? Knowledge for the sake of knowledge, quite often. It could be, for example, a review of pandemic preparedness activities or best practices in Asian countries, just to give an example. And they also help prepare loans. Why are technical assistance projects needed to prepare loans? Well, because preparing a loan is a very onerous process, right? We need to prepare anywhere from 10 to 15 different reports, 400 pages of documentation, and so on, and we need to hire consultants to that end. Grants are free money for countries. There's two types of grants. Standalone grants usually focus on fragile countries. So think of the Pacific countries like Vanuatu, Tonga, and so on. And then conflict countries, right? In this case, Afghanistan, not Myanmar, because of the geopolitics. Grants can be also linked to loans. So, either they add free money to the loan or they make the loan cheaper, right? Well, they pay for a part of the loan. And in theory, at least, grants can go up to 2/3 of the loan value. So if a loan is 100 million, grant component could be up to 65 million. Now that takes a lot of convincing, and it's very difficult, right? But the point is that in many cases we do attach grants to loans. And then loans are kind of the core of ADB's activities. The advantage of loans is that the loan amount can be very large, right? So in some cases 500 million. I worked on a loan last year for the Philippines, which was 450 million, right? So you're able to do much bigger projects, support much bigger reforms. They do have to be paid back, of course, their loans. There's two types of loans, what we call concessional loans, which are very cheap loans with very advantageous payment terms, right? About 1% interest rate, payback period of 30 years, grace period of 7 years, and so on. And these are for lower middle income countries, right? Think of countries like Laos PDR, like Cambodia, and so on. And then there's regular or non-concessional loans, which are closer but still cheaper than market values. And these are for the upper middle income countries, right? Now, the link to innovative funding mechanisms is mainly on the climate change front. Let me give you a couple examples. One of them is the facility that I just mentioned, the IFCAP facility, right, which provides guarantees so that we can crowd in 3 billion guarantees in order to get 15 billion private investment. There's other examples such as the green and blue bonds, right? Blue bonds focus on ocean activities. Green, as you can imagine, focus on environmental activities with a very big focus on climate change. One example of a green bond was in the Philippines. It was for the construction of 2 geothermal facilities. So ADB provided a 40 million loan and then a 75% guarantee, which again is insurance against non-payment, right? For 75% of the loan principal, of the bond principal and interest. So through that mechanism, they were able to raise 350 million additional. Now, and there's many other, green and blue bonds. One of them you can buy actually here in Singapore. I forget the name. There's so many of them, right? Now, The caveat, I suppose, is that these loans are very, non-surprisingly, focused on infra projects, right? Infra projects on climate change, right? Setup of geothermal facilities, windmills, and so on. Not so much on health. And that's, I guess, the linkage that I see missing at ADB. We really need to work with our private sector operations department, who are the ones doing all these mechanisms, right? That are not sovereign mechanisms, they're private sector mechanisms, right? Senior debt, guarantees, and so on. We really need to sit down with them and see how we could use those for the infra components of our health projects. Let me give you an example. Lao PDR is very interested in green and safe facilities, okay? But their borrowing capacity is very limited right now, right? They're in a big fiscal crisis. Could we think of some kind of bond mechanism to make it cheaper for the Lao authorities to be able to access the financing to be able to refurbish these hospitals, right? So I think that these discussions will be taking place going forward. I'll stop here, thank you.
Thank you. Really nice. Yeah.
Can I ask a follow-up question that's probably relevant to Alexo and also Jack? I was involved in ADB's positioning as the anchor investor for the Indonesian private healthcare group Hermina back in 2018. And Hermina was at that time probably one of the first private hospital groups to put its hand up to say we want to participate in the JKN program. Today, we fast forward 6 years, Hermina is probably one of the largest private healthcare groups. The owner tells me they deliver more babies than all of Singapore combined. Ha ha ha. So and I just wanted to get the feel from both of you gentlemen who are experts in this field. Are these good mechanisms to really leverage private sector market mechanisms? What are some of the downsides or some of the cautions that we should be mindful of?
So in the case of Indonesia, one of the real success stories is that the single payer purchaser has actually opened the market to both public and private providers. And that's great. They have, through contracts, through a clear benefit package, through contracts and through payment systems, they have opened to both public and private. And people have a choice of where they want to choose their primary health care center. So they have a choice. Of course, it's more choice in urban areas than in rural areas, but nevertheless, they have a choice. And more than half of the people since 2014 have decided to enroll with a private clinic rather than a public primary care organization. So, you know, from the standpoint of consumer sentiment, yes, consumers are very interested in the private sector in Indonesia. Of course, they, as with any private delivery system, they need to be regulated, they need to be monitored. And here, I think Indonesia is sort of behind the curve. They have good data, they have good information systems. We heard about Satu Sahat yesterday. But at the same time, they're not using their data. They're not using their data for accountability, for review. And so that's really the challenge that they're facing with making sure that both public and private providers deliver.
Yeah, so thank you. Yeah, so at ADB, you know, clearly the priority at ADB, without any doubt, front and center is climate change, okay? But there's two additional priorities. One of them is digital and the other one is private sector, right? So they've been ramping up the private sector operations department quite a bit. Not as much as the climate sector, but you know, they've been ramping it up quite a bit. And this private sector department has been developing all these mechanisms, right? Guarantees, senior debt, and so on. From what I read, senior debt may be the one with the most potential to raise private sector operations. Now, one thing that I have observed, I was just thinking about it, is that we don't talk much to the private sector operations people, right? Because we're all sucked in by our projects, right? And that's probably a link that we're going to need going forward. There was only one case for one project in Timor that I was reached out by the private sector people, and they were asking me questions, and can we support them, and so on. Then we work on integrating the private sector through other things. So what my colleague was mentioning in China, we're trying to do exactly the same thing in the Philippines, right? To integrate public with private insurance in order to achieve UHC. But that's probably more piecemeal in the government-oriented department, right? We don't have a private sector strategy within the government-oriented department, if that makes sense. That will probably be articulated over the next years. Thank you.
Thanks. I mean, this is, and we're hearing a lot of themes now around crowding in different types of blended financing and how to incent this in a productive way and how to measure it, right? Because just getting it is not enough. Well, this actually brings us, Chung, this is actually a really nice segue into your, the next question for you, which is, given that you've now heard multiple mentions now of the potential or actual roles that the private sector can play in various ways, but can we step back? Can you talk a little bit about in your, at least, opinion and experience, what are the biggest misconceptions about the role that the private sector plays in health systems, and in particular as it relates to health financing? And can you tell us a little bit about why you think these misconceptions persist? Right? There's often some very baked-in opinions.
So no, that's a very interesting question. I think there are misperceptions that are reasonable misperception. For instance, the private sectors, they are very profit-driven, that they're not aligned with the public objectives. And then also, like, for instance, private insurance companies, they're evil, right? But I think realistically, that's a realization of more sort of governmental sort of partnership and sort of regulatory reinforcement is potentially necessary, because in some extent, those are part of the potential characteristics of the private sector. So I think based on our experience, it's actually quite important to also understand what's the priorities and objectives from the private sector, what kind of game they want to in this, and then finding that alignment and the vision, and also providing regulatory and guidance through that journey in preventing some of those I think this applies actually both to the financing sector as well as the service provision. So I would say, but I just want to add one more comment on this. I think another private sector, we didn't cover this in this conversation yet, is the development of the health technology or life science industry here in Asia. So I think because, as Jeremy just mentioned, Indonesia probably the cigarette or it's a big industry. But now I think as the life science and digital health become a growing industry, maybe also in the future, climate change and health, there will be opportunity in the industry development in Indonesia, then that actually providing very strong political power for the government into providing systematic resources into the sector. So we have already starting to seeing that. That's, I think, part of the reason for them to take big loans from ADB or IFC, and then to also starting to dive into. But I think when that slowly cultivating, that also potentially providing more sort of resources to work with the health system expert together into fight for more resources into this domain.
Fantastic, thank you. No, I mean, and this is a persistent, when I got into the health world 15, 20 years ago, this was a big issue. It still is. Yeah, we're on our last round. I've been warned that we are going to run a little short on time, but these are, I think we want to kind of bring this home. Now we're zooming out again. Jack, we want to take advantage of the fact that you've done serious work and spent serious time as an analyst and leader in three of the biggest health reformers, China, Indonesia, and India. Okay. Could you identify any common innovative financing approaches that all three countries have tried over time? And then finally, if you could, pick out anything unique in at least one of those countries that nobody else has tried.
Okay. Yesterday, Dr. Vijay talked about the fact that he could identify a problem. he could identify a way to solve the problem, but then he needed to change behavior. And that's where I think innovative financing can be a very useful tool to actually change behavior. I think that in all three countries, what we see is these are large federal states, very decentralized in different ways, but nevertheless, you know, something happens at the national level, at the provincial level, at the district level, at the village level, right? And so we see that. And we also see that the great majority of funds flow from the national level, right? And I think what I saw in China several years ago, when I was there maybe 15 years ago, the social health insurance program for the rural families and farmers, that was amazing. So the national level put in 65%, and they said to the province, are you interested? Are you interested? Of course, they were interested for coverage, so they put in 20%. They asked the counties, the districts, to put in another 5%. But then they also said to the party leader in each county, here's your quota. Here's your quota for coverage. And we want you to scale up over the next 5 years to reach 100%. And if you don't reach that quota, you're probably not going to go very far in our party. And so I talked to many county leaders who said, at night, I would go and knock door to door, and I would ask families, can you please enroll? And if they said they couldn't afford it, we waived the premium, which was only a small amount, but we waived the premium and we got them enrolled. And over several years, I mean 3, 4, 5 years, they reached 100%, almost 100%, maybe 98% coverage. Hundreds of millions of people. And basically what they did was they used their financing in a way that coordinated and that incentivized the local leadership to make sure that these people were enrolled, and they achieved that. On the other hand, if you look at Indonesia and India, they may coordinate, but basically these are multi-party systems. There are fiscal transfers, and fiscal transfers are often sent without any monitoring, without any reporting back. In Indonesia, you know, if you're leading a public primary care clinic, you're getting money from the insurance fund, but you're also getting 4 or 5 different fiscal transfers, but they all have different rules and regulations. And often they don't know how to use them. Even in the poorest districts, there's not that capacity to really know how to use these fiscal transfers because they do have rules and regulations to each of them. And so a recent study found that these providers are only spending 80 to 90% of the money they receive, their line items, and they send money back because they don't really know how to use it effectively. They don't have the capacity. And in India, it's the same way. It's not 4 or 5 lines in India. It's there are what, hundreds of line items. I think someone told me once in India there's over 1,000 line items, and they also don't spend money well. The Gates Foundation looked at Bihar and UP, 2 of the poorest provinces, and they found that up to 30% of these allocations were sent back at the end of the year. So this is a big issue. You know, I was in Delhi once when Bill Gates was there, and he went to see Mr. Jaitley, the Minister of Finance, and he said, Mr. Minister, put more money into the health system. And the Minister of Finance looked at him and said, Bill, they don't spend it well, and they send it back at the end of the year. Why would I put more money into the health system? So I think this is really a challenge, and I think that I would like to see not only innovative financing, but I would like to see the public financial management systems in some of these countries having more transparency, having more flexibility, so that we're really ready for the next pandemic, and we're also more resilient on a year-to-year basis in terms of how we spend the money.
Fantastic, thank you. No, that's really good food for thought. And I mean, and it shows that we're not going to have a one-size-fits-all, right? I mean, this is going to be the case, but there is potential. Last 2 questions, and we're going to have to wrap up. But I don't want to cut out any great ideas. Jeremy, we know that Western Europe is old, but Asia is aging incredibly rapidly. And with the exception of a few countries, including Singapore, there are not large immigrant flows into countries. So this is going to be a permanent condition. The worker kind of retiree ratio is changing rapidly. And many of us fear that as demands on both the health and social service and pension systems increase rapidly, that the math is just not going to work in terms of financing health systems. What are one or two innovative financing mechanisms that you think hold real promise in Asia that have not yet been tried or tried at scale to impact on this, if any? And if there's nothing, say there's nothing we can do.
And if I knew the answer, I wouldn't be sitting here. Right. Honestly, I don't think there is a good answer beyond managing expectations and tinkering, or rather being much smarter on the provision side than on the delivery, than on the financing side. I know Hong Kong has been piloting the use of time banks. So healthy seniors will do good work and bank it so that when they're less healthy, they have accumulated a couple of 100 hours, that the next generation of healthy seniors will then pay it back to these persons. So that's something that Hong Kong has done around time banking, that's slowly taking off. Here in Singapore, and I'm going to put my foot into my mouth here. About more than a decade ago, the then health minister kind of suggested that Singapore was a really expensive place to grow old and retire. Perhaps the region could offer good value for the pensions that really Singaporeans receive in Singapore dollars. Of course, he was lambasted politically for it, but from a pragmatic point of view, the strong Singapore dollar goes a lot further in most of the countries around the region. And and if there was a way to politically think of the broader Asia region, where we have young countries, we have older countries, and can we help each other out, right? Some of us need care, we've got money. Some of us need jobs, we have less money, right? Why be limited by geographic constraints?
I think that this is not crazy. I mean, regional solutions at some point will have to be...
It's politically crazy, though.
It's politically sensitive. Yes. Kerry, final word from you, and then we'll wrap up. As part of the OECD, you've got a broad lens on both OECD and LMIC health systems. Given that OECD systems are somewhat more mature and certainly a lot better financed, what rich country reforms in the areas of innovative financing have actually moved the needle significantly on overall spending envelopes for health? We're coming back to that, is there more smoke than fire question. And how applicable are any of these solutions that you can identify, if any? How applicable are these to less well-endowed countries, middle-income countries that are right now engaging in aggressive health reforms?
So thanks for that. That's a very interesting question, and I don't think I'm going to give you the answer that you'd necessarily expect. So just maybe a little bit of history here in terms of innovative financing mechanisms again, in that some of the most famous of those, of course, started in OECD countries, and I'm thinking here of the X Prize, which we've already referred to today, about the world's first spacecraft flight with a $10 million prize, etc. And that was inspired by early 20th century aviation prizes. And the whole aim was, of course, to develop this new low-cost space flight industry, which is very much flourishing now. But when you really look at where this developed, and I think I gave a hint to this in my my opening comments, it was really at the turn of the century, when especially when public finances started to become more and more constrained, and particularly because development is usually the first sector hit when that happens. Aid budgets are very easy to cut, and so therefore there's a big pressure to look at innovative financing there, whereas it's easier for politicians at national level to find the money, as we saw with COVID, for reforms at national levels in wealthier countries. It's not so easy for that to happen in developing countries. So what I'd say is that that initial idea of innovation or prizes went on to really inspire what happened in developing countries, particularly in tough times. And pneumococcal, we've talked about that earlier, but there's also many other examples of how that idea of innovative finance has been replicated in other areas in development. So I'd say it's not so much about what OECD countries have done, but what they can learn sometimes from the development sector on innovative financing. And actually in our health committee, we've recently had a paper full of developing country examples to OECD health delegates about the sorts of things that they might look at for increasing innovative finance in R&D investment in OECD countries, to give you some idea there. Of course, some of the biggest innovations and examples to follow, we can look at the vertical health funds, Gavi, the Global Fund. They've done quite amazing things, but not necessarily easy to replicate. So, for example, some of the newer ideas around debt for health swaps might work when you're Gavi or you're the Global Fund, but very difficult to make work and very high transaction costs when you look at how other actors might do that, including through blended finance initiatives. So air ticket levy schemes, again, I think we've seen that as something which started really as an idea to have with an objective of development benefits. We're now seeing it applied much more broadly back in developed country environments or middle income country environments to deal with a whole range of global sustainability challenges. So no longer so focused on unit aid, which was the initial idea for treatments for AIDS, tuberculosis, and malaria, but much more focused on broader challenges and other sustainable development uses. So again, I'd say it's a two-way street. Insurance, for example, and I could go on and on here, but I won't. I know we need to end this. But insurance is an area where obviously there are key lessons which developing countries might learn on both insurance and on social protection mechanisms from middle-income countries as well as from advanced economies. But it's interesting to see that it's not as it's not a lesson necessarily from OECD countries to developing countries, but often the other way around.
Thank you so much. Yeah, and I think we're left with a deeper sense of the possibilities, but at the same time, a realistic sense that there won't be an easy or quick or common answer to all of these challenges. We are unfortunately at time. So in the spirit of doing things a little bit informally, we probably could continue the Q&A over lunch. You're all going to be sitting in the same place, so people are going to ask you questions. I would just say personally, I mean, having before this session kind of thought of most of you as boring, uninteresting, slow-witted people, well, my opinions have changed. I think you're actually bright, rapid-thinking, interesting people who do have a lot to say, and I hope the audience's perceptions have also changed along with me. So a big round of applause. Thank you so much, and we will do Q&A over lunch. Yeah? All right. I don't mind. Thank you for the valuable session, and let's just stop there. Well stewarded. My query for Kerry and others is if you have exemplars of organizations or nations who have done well with anticipation and surveillance, number one, and prompt and innovation action in the areas of meso and macro level resilience. You could take that in any number of directions. Carrie, best of luck to you.
Countries that have done well. Oh, sorry, I'm losing my video. Countries that have done well on surveillance. I guess it really depends on what you want to see, or what you think success looks like. I mean, initially, in the OECD context, I think we looked at countries that closed borders, and I'm thinking of my own country, Australia or New Zealand, around that with COVID, for example. And in the end, what we found was, of course, that wasn't as great as we might like to have thought it was, for a range of reasons, including some of the longer term impacts that are going on. We saw in a range of Pacific Island countries, for example, massive economic and social impacts from which countries are still struggling to recover. So how could that have been more innovative during the COVID period? How could have vaccines been delivered in a more innovative way? There are many lessons. I'd really encourage you to have a look at our soon-to-be released COVID evaluation. The OECD is a very big evaluation hub, but we actually are housing a COVID evaluation coalition. And there are many lessons, including on some of the innovative ideas around this. And one of those, for example, was in regional practices, which was about buying at the same time, some OECD countries, for example, at the same time bought vaccines for developing countries, often in the Pacific region. So that would be one example of innovative best practice, I guess. It sounds like common sense, but which was seen as relatively innovative at the time.
Okay, thank you. Thank you for wrestling with that. That was really helpful. Now it's 5 a.m. I guess you'll just be waking up now. So we'll put you on speakerphone during lunch. We'll take it. No, she's now awake. We're going to put her on speakerphone. No problem, right? You know, even if you're in the shower, it's fine. So we should wrap up, and then you can do Q&A over lunch, right? I mean, people will be, I think, coming to talk to you, bright, smart, quick-witted people, okay? This was really interesting, you know, and I think it's an important session, and it's going to be a persistent challenge over the next couple of decades in this sector. So thank you very much. Round of applause, hopefully.